So this is Pediatric Medication Math, and it comes from Chapter 13 in our textbook. So the first thing I want to point out is just how different pharmacodynamics are on children. And if you remember, this is that ADME, absorption, distribution, metabolism, elimination. For absorption, oral medications, children have slower gastric emptying, so those medications that are absorbed in the stomach are going to have more time to absorb. They have increased intestinal mobility, so those medications, which is most medications, that are absorbed in the intestines are going to have less time to absorb. And they have less acidity, less acidic stomachs, the stomach juices. So those things that are changed or affected by the acid in the stomach are going to go through less of that change. For IM and sub-Q, children have pretty unpredictable absorption. They have less muscle mass and less muscle tone, which affects the absorption, but the big difference is that they just have such variable perfusion. A child who's cold doesn't perfuse well to the skin and the sub-Q and the superficial muscles, which means they're not going to absorb, where if they're nice and warm, they will perfuse there, so it's not very predictable of how rapidly it will be absorbed. Topical medications absorb more rapidly on children because they have a larger body surface area to mass. On infants, more and more rapid absorption because they have more permeability of their skin. As far as distribution, it's affected because children have a higher percentage of their body as water compared to adults, which means there's more shifting between the plasma of the blood and the tissues, which is how medication's distributed. A lot of medications are kind of stored in body fat. Well, children have less body fat. If you remember that first pass, oral medications get picked up in the gut and first brought to the liver. Well, children have an immature liver, so there's less first pass effect. And if you remember protein binding, that medications that are highly bound to protein are not available to work. Only the free medicine that's not bound is available to work. Well, children have less protein in their bloodstream, which means they're going to have less protein binding, so there's going to be more medication available to work. And then there are some medications that we don't give to children because children, particularly infants under 2 to 3 months, don't have a well-developed blood-brain barrier, so what's in the bloodstream does cross into the brain, which is not true on adults. As far as metabolism, most medications are metabolized in the liver, so they're changed into a form that the body can then get rid of. Children have immature livers. They don't have those enzymes that do that metabolism. However, they have more rapid body metabolism. So that changes the breakdown of the medications. Most medications are eliminated in the urine by the kidneys. Well, children have a very immature renal system. That's one of the later systems to mature. They're almost 2 years old before the kidneys are very good at being able to change, conserve, or dump out more things. So that means they're not getting rid of medication as rapidly. Longer half-life of the medication, higher risk of toxicity. So keeping all that in mind, let's talk about how we're going to do math for children. And I would say those things are the reason we want to do math for children. We want to make sure every medication we give, we're giving a safe dose because we know we have higher risks with children with medication. So every dose, we're going to calculate what the usual safe range is. If a patient's weight happens to be in pounds and ounces, we have to convert it to kilograms. And then we're going to calculate the range based on both the child's age and diagnosis. And we're going to see what the usual low dose is. If it's less than that, it's not going to be therapeutic. And what the usual high dose is. If it's more than that, they can become toxic. And we're going to make sure that the ordered dose falls between those two numbers. So let's do that. Let's say we have a 4-year-old with pneumonia, and our provider gives us these orders. Acetaminophen, 200 milligrams, oral, PO, whichever way they write that, every 4 hours as needed for fever greater than 38.5. They also order ampicillin, 360 milligrams IV every 8 hours. So we go to our drug book and we look up the usual safe range. And it tells us for acetaminophen, the usual safe dose is 10 to 15 milligrams per kilo per dose. And it tells us for ampicillin, the usual safe dose. For pneumonia, it's got different dosing for an ear infection, for pneumonia, or for meningitis. And it's got some differences based on age. So for pneumonia, for a child over 4 months, and we have a 4-year-old, that we should be giving between 50 and 100 milligrams per kilo per day. And that amount is going to be divided into 2 or 3 doses. So let's say this child weighs 18 kilos. So we go to that usual safe dose for acetaminophen. We said it was between 10 and 15 milligrams per kilo, and we're going to plug in this child's kilos. So 10 milligrams times 18 kilos is 180 milligrams. 15 milligrams times 18 kilos is 270. That's already per dose. So we're going to look at our ordered dose and make sure it's between 180 and 270. The ordered dose is 200. Good. This is safe. We're going to give it. Right? We are the last double check to make sure that the child's getting the appropriate dose. Now you're going to do the math you're used to doing. Now you're going to figure out, I want to give 200 milligrams. The bottle I have, you see it over there, has a concentration of 160 milligrams and 5 mLs. How many mLs am I going to do? So that's our usual math that you're used to doing. For ampicillin, we're going to look up, it tells us to give between 50 and 100 milligrams per kilo per day. Again, we're going to plug in this child's 18 kilos. So 50 times 18 is how much we want in a day. We're giving 3 doses, so we're going to divide that total into the 3 doses. So divide it by 3 gives us 300. 100 milligrams times the weight, which is 18, divided into 3 doses is 600. So we expect to see between 300 and 600 on that order. 360 is our order. We're good. It fell between 300 and 600. Some of you are saying, how did you come up with the divide by 3? Well, I know there are 24 hours in a day. And my order said every 8 hours. So I'm going to take 24 hours, divide that by 8 hours. That comes out with 3. So 3 doses in a day. If it were ordered every 12 hours, I'd do 24 divided by 12. I get 2 doses in a day. Say it was every 6 hours. 24 divided by 6, that's 4 doses in a day. And then we put it on a pump. This is the pump we use for most of our medications at Valley Children's. You may have more math to do now. You may have to figure out, based on the volume and the time you want to give, how you're going to set this pump. Another piece of math that we do for children is fluid maintenance. Fluid maintenance is how much fluid you need per hour to maintain where you're at. If you get less than that, you're going to start getting dehydrated. If you get more than that, you might get fluid overloaded if your kidneys can't dump out the extra. So the fluid maintenance formula that we're going to use is for the first 10 kilos, anything between 0 and 10, we'll multiply by 4. Anything between 10 and 20, we multiply by 2, and everything over 20, we multiply by 1. So let's take an example of a child who weighs 22 kilos. Those first 10 kilos, from 0 to 10, we're going to multiply them by 4. It comes out 40. The next 10 kilos, between 10 and 20, we're going to multiply by 2. So those 10 kilos times 2 is 20. So now we're up at 20. We have 2 more kilos because he's 22. So we're going to take those 2 kilos that are over 20 2 times 1 is 2. Add all those together, 40 plus 20 plus 2, we get 62 mLs per hour. That's how much this child needs to stay where they're at. That's how much they need either orally, and if they're not taking orally, that's how much we're going to give IV to maintain them where they're at. So let's look at a provider order. They order IV fluids of D5 half normal saline with 20 milliequivalents of kCl per liter to run at 1.5 times maintenance for 12 hours and then saline lock. Okay, let's break this down. D5 half normal saline with 20 milliequivalents of kCl per liter, that is just the name of the solution. That's like normal saline. That's like LR. It's just a really long name. That's our most common solution in pediatrics, actually. But none of that has anything to do with the math. That tells you what bag to go and get when you get it out of the supply room. Next it says to run it at 1.5 times maintenance. Here's our math. We've got to calculate fluid maintenance. This child weighs 12.5 kilos, so let's do that. That first 10 kilos from 0 to 10, we're going to multiply by 4. We'll get 40. Between 10 and 20, we have 2.5 kilos. So we're going to take that 2.5, multiply it by 2, that's 5. We have nothing over 20. So now we just take that 40 and that 5, add them together. This child's fluid maintenance is 45 mLs an hour. For some reason, this child is losing more fluid than is average. So instead of running maintenance fluid, we're going to give them 1.5 times maintenance to make up for that extra loss that they're having. So 1.5 times 45 is 67.5 mLs per hour. That's what we're going to run this child's IV fluids at. And then we're going to stop. That 12 hours has nothing to do with calculating fluid maintenance. Think of it as a totally separate order. So we've calculated 1.5 times fluid maintenance. We set the pump to run that at 12 hours. This next part of the order tells us in 12 hours, go in, turn off the pump, and saline lock the IV. So it's a separate nursing action. It is not in the math. Many children who come in needing IV fluids come in dehydrated. Maintenance just maintains you. We don't want to maintain them at empty. We want to first take them from empty, get them up to full, and then maintain them at full. So we're going to do that. We're going to get them from empty to full by giving them a fluid bolus. Most of the time, we're going to give 20 mLs per kilo over 20 to 30 minutes. This is the pump we use at Valley Children's. It's the Sigma pump. Notice it works in mLs per hour. Pumps can only think in mLs per hour. And even though we want to give this bolus over 20 to 30 minutes, we've got to figure out what would that be equal to per hour. So let's do that math. We have an order for normal saline bolus of 20 mLs per kilo over 20 to 30 minutes. And we have a baby who weighs 9.6 kilos. So our 20 mLs times our weight of 9.6 gives us 192 mLs to be administered. Now we've got to do the math. We want to give 192 over 30 minutes, and you can set that up with ratio proportion across the equal sign and cross multiply if you like that, or you can set up as dimensional analysis where you cancel the minutes and end up with mLs per hour and just set up the equation where you work across. Either way, you end up with 384 mLs per hour. That's how we're going to set our pump. But when 192 have gone in, we turn our pump off. Maybe we want to give it a little faster. Instead of that 192 over 30 minutes, we set it over 20 minutes. Again, you can set up ratio, you can set up dimensional, but that's equivalent to 576 mLs per hour. You set it to give that much per hour, but after 20 minutes, when 192's gone in, you go in, you turn it off. And that is medication math for pediatrics.